Hello, everyone. Very excited to see you all here and to be participating in this exciting workshop that's linking so many amazing people from around the world. I've enjoyed my two rapid breakout sessions already. Really, it's been a great learning who's here to share. We have a wide variety of people, some people who have not heard of female genital schistosomiasis, others of you have a lot of experience, but we wanted to make sure that everybody had the background information so that then when we go into our breakout groups and we start to talk about cases, we're all aligned on what FGS is. So, and moving forward from this, thank you for coming. Why FGS? Why female genital schistosomiasis? Well, schistosomiasis is a very widespread problem on the planet, affecting over 450 million people who live at risk of this infection. And within that group of people, there's this hidden type of manifestation of infection with schistosomiasis, which is the female genital schistosomiasis, which goes unrecognized. And that can, we believe, working with the World Health Organization, that there's about 56 million women that are affected by this. And that is caused by one specific type of schisto called schistohematobium. And you see that on the map there on the side. These are the areas and parts of Africa that are affected by hematobium and are at risk of having women and girls that are affected by female genital schistosomiasis. So it's a very widespread problem, even though it's very poorly recognized. So schistosomiasis is throughout Africa. It's in rural and urban areas. Basically, it's transmitted by people having contact with water that's been contaminated by the parasite. And that comes in the case of schistosomiasis hematobium from urine that has been from an infected individual getting into the water. It affects snails, and then the snails, it multiplies within the snails, and then comes out of the snails, gets into the water, and just contact with that water. It's not about drinking water, it's having contact with that water. The parasite penetrates the skin, gets into the human host, and then replicates or grows in the host. And then it's really the eggs of the parasite that cause the problem. The eggs of the parasite then live in the urogenital part of the human body, and then the eggs implant themselves into the urogenital tissue, and that's what results in the inflammatory response that causes female genital schistosomiasis, and also the most common symptom that people generally know, which is the blood in the urine. And that's when the eggs are then re-released into the environment, and that continues the life cycle of the parasite. So women and girls who have urogenital symptoms have had some contact with fresh water. And as we know throughout Africa, that contact with fresh water is a part of everyday life. And symptoms of this, the things that people can present with, is vaginal discharge, a bloody discharge. You can have bleeding after intercourse or pain after intercourse, genital itching and burning, blood in the urine, as I mentioned earlier. And then girls and women can present with these symptoms. And so it can be very confusing. This actually came up in one of my breakout groups already, that in young girls, this can be a very confusing symptom. And as you see, none of these are very specific symptoms. So so it can be confused with other things, which is one of the problems. We have several experts on looking at the cervix. This is a picture of the cervix from a cervical exam. And when the definition, or the way we define and diagnose female genital schistosomiasis, is by visual inspection. So, and when you look at the cervix, you see these specific lesions to female genital schistosomiasis with the grainy sandy patches. So they have kind of a yellowish color to them, these homogeneous yellow sandy patches, and rubbery tubercles. And when there are questions on this, we have several people in the SME group that can really give you some more ideas about this and what you find on exam. And in the picture here, the arrows are indicating different areas of abnormal blood vessels and of these grainy sandy patches. So there's several complications. So when the eggs are deposited in the genital tissue, besides getting those lesions, things that can happen is that the inflammatory response that happens around these can lead to tissue friability, where that tissue gets very inflamed. That results in the discharge that you see, and it can cause bleeding even during the examination. In touching the areas, you can get bleeding that happens with that, which we call contact bleeding. It can result in, we're in the picture I showed you, we're looking at the cervix, but it can go throughout the genital tissue. And so depending on where the eggs are infecting and implanted and the inflammatory response, it can result in infertility, abortion or ectopic pregnancy. It can result in problems with urination and incontinence, ulcers, tumors and swelling, there are other complications that go with just being infected with schistosomiasis, because it's a chronic parasitic infection that has an inflammatory response, can result in many things that result in damage to the host, which you see here in the other complications of schistosomiasis, including anemia and stunted growth. So what do we do? How do we treat this? What is the response to this? We use praziquantel is the drug of choice for this. It's 40 milligrams per kilogram as a single dose. And this kills the adult worms and prevents new lesions of FGS coming. It can improve the symptoms, but to have the best outcomes, people need to be treated early. And so the mainstay of the program is really trying to reach people as early as possible to decrease the ongoing symptoms that increase with time and duration of infection with schistosomiasis. So prevention, where we want to be is preventing female genital schistosomiasis. When people are infected, we want to be able to treat them and get them properly diagnosed. But the most important piece is actually to prevent them from ever being infected. And so FGS, as we said, is transmitted through contact with water, which is part of everyday life for many people throughout Africa. And so what we need to do is have children who are and communities that are at risk treated with what we call mass drug administration, which means that once we identify what communities that are at risk, all school-age children are treated regardless of knowing whether they're infected or not, because early infection is asymptomatic. People do not know that they're infected. And with ongoing exposure, the amount of infection goes up and up because the parasite doesn't continue its whole life cycle within the human host. But with continued exposure, you get more and more infection with that contact with the water in your activities of everyday life. So the most important thing is making sure that communities are aware of this and that they take the praziquantel. And the thing that we also need to remember is that it's not, the school-age children are not the only ones at risk. And so one of the challenges that we need to figure out how we overcome is making sure that praziquantel is available outside of the mass drug administration and available to communities that are at risk, and especially to women and girls at other points of contact within the health system. So the challenge with FGS is that the symptoms are very, they mimic other symptoms. So the most common thing here, and you see this in the graphic over here, is that a woman becomes ill with and starts to experience symptoms. She goes to the health post, and most commonly she'd be diagnosed with a sexually transmitted infection, believing that it was a sexually transmitted infection and not suspecting FGS. And this cycle can happen many times. She'll go and get the drugs. The symptoms don't improve. She goes back. It's believed to either she didn't take the drugs or that she's been reinfected. So this cycle can happen many times. And then this can happen even going from the health post, going to a district level, all the way up to the tertiary care level. And unless people are aware of what the lesions of FGS look like, this misdiagnosis cycle can happen throughout the health system. And this is the problem that we're trying to solve by improving clinicians' awareness and health practitioners' awareness of FGS throughout the entire health system, because this cycle of misdiagnosis can be stopped at any one of these levels and proper treatment given with praziquantel. So with FGS, there is stigma, and I think this is an important thing to recognize because there are sexual and reproductive health issues. So women who cannot have children, this can be a significant issue within their communities. The also being repeatedly diagnosed with a sexually transmitted infection can cause big problems within families and cause strife between spouses when one believes that the other is infecting them with a sexually transmitted infection, which is actually not a sexually transmitted infection, but a parasitic infection. And this can be a very big issue when we talk about school-age girls who are not sexually active and people believe that they have a sexually transmitted infection. So stigma is a big piece of this, and erasing that stigma and getting people the care that they need is also a huge priority within. And there's been some really interesting stories around this where women have been misdiagnosed and had that stigma associated. So the challenge with female genital schistosomiasis is that it's a parasitic infection. However, it presents with sexual and reproductive health symptoms. And so women who have this are not seen by a parasitologist or somebody who is focusing in that area. And so we need to see female genital schistosomiasis as part of the health system. So that means linking in with the HIV and AIDS community, linking in with those seeing cervical cancer, linking in with sexual and reproductive health more broadly, so that everybody within that system is aware of FGS, and so that women can be treated properly when they're seen, diagnosed, and then solving the problem and figuring out how FGS is integrated into those systems can only be done by the countries working together closely within their system to make sure that the awareness is there and that it fits into the system and how that's working at the country level. And so fitting within that, and one of the authors of the paper who did this this nice diagram is one of our SMAs. So we have people that can help think through and talk through this as you guys are thinking about what does this mean at the national, subnational, and community level in your own country and own setting. So one of the first challenges has been what does it mean to know, what does it mean to be competent in treating, diagnosing, and preventing female genital schistosomiasis? And this became a challenge when we were talking with the World Health Organization and others who were interested in supporting some training in this. So, but the question is, what do we need to train people on? So we started a process in July of 2020 where we brought together a group of participants, 65 participants from over 24 countries, working in 15 different endemic countries, and to define what it means to be competent and able to diagnose, treat, refer, and prevent female genital schistosomiasis. We did this in collaboration with the Geneva Learning Foundation, and it was in 4 sessions over 3 weeks. And the outcomes of this is really meant to help us develop this online course, but also to be used by anybody who is trying to train people in female genital schistosomiasis. And you will have seen these competencies as part of the background materials that were provided to you in preparation for this workshop. And if you haven't had a chance to take a look at those, they will be very helpful to you. They basically fit into 2 categories. The clinical setting, and when people are working in a clinical setting, what do you need to know what to do? And then similarly, what do you need to know when you're working in a community setting in order to be able to diagnose and identify women at risk and girls at risk and prevent schistosomiasis? So a total of, we had at one point, I can't remember how many, but a lot of competencies. We worked with these, put them into categories, simplified them, and ultimately ended up with 27 competencies. 10 of those fit into the area of diagnosis, 6 in treatment, 6 with identifying women at risk, and 5 around prevention. And these are the things that we hope at the end of this workshop you feel comfortable with all of these competencies and feel comfortable sharing those and helping your colleagues learn about those competencies as well. So as I mentioned, I'm not the only subject matter expert on this call, and I'd like to specifically ask 2 people to make some comments. One is Pamela, who I see on my screen anyway, saying something from the World Health Organization, and after that I'm going to ask Eyrun Kjetland to talk a little bit about the clinical experience. So Pamela, would you say something to us about from the WHO perspective?
Okay, thank you so much, Julie, and good afternoon or good evening, good morning to you all once again. Complement what Julie has said by highlighting what WHO is doing about this. In addition to what, I mean, whatever Julie has said clearly, you see that we have a great challenge before us. And as WHO, we have recorded and worked with we know that there are 78 countries out of the member states of WHO that are endemic, out of which there are 240 million individuals who require treatment presently with preventive chemotherapy, these mass treatments that Julie has mentioned. And most of these treatments need to occur within Africa, the majority of them, more than 90% of them. And the coverage is not where it should be. We should be reaching the majority, at least 75% of school-age children. Even with our best effort, we've only managed to reach 67%, and that's only in one age group. For the adults, we are only reaching about 17%. So that means there are a lot of people who are still being infected and not being treated, and that means that for the next foreseeable decades, without this treatment scaling up, the risk of individuals developing FGS remains quite significant and high. So it's important that clinicians know and recognize this infection. As Julie mentioned, we estimate that at least up to 58 million women in Africa alone have FGS. So WHO, what we've done is we put forward a strategic approach in public health terms of how to address this issue. Our mainstay is preventive chemotherapy with praziquantel, for which we have a large donation at present, and we use to do these mass treatments. And some countries also take the approach of targeted treatments to specific at-risk individuals. That's one approach. So prevention is the main thing, as you learn by the end of this workshop, why that's our mainstay. The other important bit is health education. You can see this workshop is part of that, educating health workers and increasing clinical awareness, the clinical index of suspicion of this infection, but also in educating the community themselves, and so that they understand how they are acquiring this infection. So WHO has collaborated, as Eyrun mentioned in her introduction, in developing WHO Pocket Atlas, and a lot of the images you see come from some of the work that Eyrun has been doing over several decades. And this is something that you as health workers, we expect to become very familiar with, along with the poster that WHO developed to support your work. Similarly, we've developed small booklets titled Bamboo Has Schisto, which are available in French and English, and accessible also online, which we encourage to distribute to school health children so that they understand what is happening about this information. And we look forward to working with anyone else who can help extend this health education piece. The other guidance we've given out is for vector control in terms of controlling the mollusticiding work, dealing with the vector, and also some environmental management measures, along with the guidance for water, sanitation, and hygiene practices that are key to breaking the cycles of transmission, some of the cycles that Julie portrayed. So regular treatment with praziquantel is the key, especially starting early from all age groups. And the current roadmap that we've put out for as the department that targets, that highlights our interventions between the years 2021, this year, to 2030, leading up the SDGs, call for treatment of all at-risk groups, preschool age children, school age children, and others, so that we leave no one behind. And surely, by the time other important milestones for reproductive health are being met, we should have made a significant impact in reducing the global burden of disease for FGS. It's also important that as health workers, you are aware about FGS among travelers. It's not just individuals who live in rural areas that are endemic. There are several published case reports that highlight the importance of health workers knowing about this, because you know about the rural-urban movement in country, within endemic countries. There is seasonal workers who migrate for work. They also presently, we are seeing a number of cases in Europe because of the Mediterranean crisis of some of these individuals who are crossing. And there was an outbreak, for example, that was also reported in France as a consequence of this. So it's important that those who work with travelers and international health are also aware about FGS. Documentation and reporting is extremely important for us as well, because right now our global burden of disease for FGS needs to be improved, the estimate we are working with. So we hope that out of this workshop, you will be part of the mechanism that will strengthen national health information systems to help reporting on FGS. And in all this, as Julie highlighted in her presentation, the key thing is to integrate FGS prevention and treatment into broader platforms for women reproductive health. This is also part of the sexual health agenda that's being promoted by various agencies, notably including our collaborators in UNAIDS, with whom we have had a joint publication that really pushes this approach for integration. And also they've developed the UNAIDS Global Strategy 2021 to 2026, which highlights the importance of treating at least 90% of females for these conditions that are linked also with HPV, cervical cancer screening programs, STI, and HIV prevention activities. So this is something that we as WHO are working with collaborators and also encourage you and hope to learn from you during the course of this workshop how this could be best done operationally in your settings. I realize you have very little time, so I'll stop here and allow time for the next speaker, because otherwise we'll get cut off by Reda.
Thank you, Pamela. And you know, one of the really important pieces you brought up is the association of female genital schistosomiasis with HIV. So women, and I think Eyrun can speak very eloquently to this. And so Eyrun, would you like to say something from the clinical perspective?
So Julie, we have a first question from Millicent Selassie Afatodzi, who says, please, I'd like to know if infertility as a complication can be reversed, or is it permanent even after treatment is given?
And that's a perfect question, transitioning over to Eyrun.
Eyrun, I'm asking you to unmute.
Muted. Oh, there. Okay, yes. Fine. Wonderful. The clinical meetings with our patients is actually a scenario which is quite different from the ordinary gynae examination. So in an ordinary gynecological examination, they are really focusing on the cervix only, usually. And if you present with a fertility problem, then you might have blocked tubes in addition. There are case reports of people who've been treated and who have regained fertility. And I have anecdotally in Zimbabwe, when I was working as a clinician there, treating many women, people who had been fertile, so secondary infertility in particularly seems to be associated with it. We published one paper on this, and there's subsequently another paper from Kenya that indicates that there is subfertility, so less children being born to women with female genital schistosomiasis. Anecdotally, it's reversible, but it hasn't been proven in any studies. I would also like to say something about the clinical examination. It's a tricky thing to learn this. Some of the changes are subtle, and you'll see the images that we show you. They're quite obvious. You will see a lot of eggs, or a lot of grains, and a lot of homogeneous yellow sandy patches, because we had to put that in the atlas. But sometimes you just see it in a little corner. And it's not just the cervix, but it's the whole vaginal tunnel. So you must think the whole wall, the fornix is at the top. So you have to visualize all sides of the vagina. And some of the images we can show you also show that it kind of overflows from you see it on the cervix, and you see it on the wall of the vagina as well. And we know from post-mortem studies that there's equal amount of eggs sort of spread around in the whole genital system. What's unusual about this disease is that every woman you meet is a patient who has sisters and children. So gynecologists don't usually think about their sisters and children. Infectious diseases doctors meet a TB patient, you think about the whole family. But a gynecologist doesn't think about the whole family usually. And this is where we come in as public health specialists and as schisto experts. And after this meeting, you all will have this knowledge, much more knowledge than your local doctor will have about this, that you actually need to go beyond the call of duty and see just your one patient who has your problem, but you also want to try to prevent all the others who have water contact, the same water contact as she has. All her sisters, all her girls might be suffering from the same problem. We've also published a study in the youngest girls we could talk to clearly about whether they understood, the difference between vagina and urine and what's going on, down there. 10 to 12-year-old girls tell us they have stinking discharge, burning sensation in the genitals, sores, bloody discharge, and this is before they are sexually active. Highly associated with schistosoma hematobium in particular. So that's also an issue that you need to take along, that little girls have been accused of having sexual debut. Teenagers have. We've just published a paper now which shows that if we treat, it looks like if we treat KwaZulu-Natal province, where I've worked mostly, we would be able to prevent about 5,000 HIV cases per year if we treated schistosomiasis. This is just a calculation. So it's a way to move forward some of these areas where you have your internal damages, if I have them and you don't have them, those FGS damages, if I sleep with an HIV positive man, I'm more likely to get HIV than you are. And that's where we think the HIV, and the same goes for cervical cancer. So HPV virus comes in, starts the damage much more easy in my genitals than in your genitals. So this is what we have in front of us. And this is not being diagnosed at the moment. Our task as we move along.
Thank you, Eyrun.